Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm really delighted to bring to you today our 50th session of the Community of Practice that we co-host together with the Ontario College of Family Physicians. And I'm going to turn it over to their new president, Mahala Kuminen, to introduce the session. Mahala?
Thank you, Tara. Good morning, everyone. I'm so pleased to be here today. My name is Mahala Kuminen. I'm the president of the OCFP as of last week. We have a really informative session planned as we head into the fall. And I would like to just take a moment to thank our panelists and all of you for being here today. Just a reminder, this is a Maine Pro accredited session and details will be sent to you after the session. Next slide. Okay, so for our land acknowledgement, I'll just read this. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DCFM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation.
Thanks, Mahala. I wanted to today reflect on new research that was done by my colleague Janet Smiley and her team at the Well Living House through the Our Health Counts project. They've been doing this research in several different cities in Canada. This one is in Kenora, their latest research, and it was really striking. I've put some of the striking statistics on the slide here. They found really high poverty rates among people who are Indigenous, but I thought the healthcare pieces that they found were particularly striking and important for us. That 1/3 of Indigenous adults in Kenora didn't have a regular place to go for health advice or when they were sick, and that 40% of Indigenous adults reported that they'd been treated unfairly by a healthcare professional because of their Indigenous identity. 14% reported avoiding health or social services due to discrimination, and almost 1 in 3 Indigenous adults reported racism and said that it affected their overall health and well-being. So I think some really sobering findings from this research that I know caused me to reflect on the kind of care that I provide and how I could do better to ensure that I'm avoiding racist and colonial actions, however inadvertent they may be. Slide. We're delighted to bring you this session, which is one, of course, of our series, and today is our 50th anniversary. Woo! And we're at 50th session, I should say. It's not that we've been around for 50 years, 2.5 years, but 50 sessions. And you can, of course, read all of our, view all of our past sessions and read those session materials on our website. And we're going to do a little thank you for our wonderful planning committee who's really been behind the scenes working hard for 2.5 years to pull these together. Next slide. So yeah, 50. Next slide. So I'm also excited that today we have a great group of panelists to welcome us to this 50th session. Dr. Nicole Blackman, who's new to us, but Allison McGeer and Daniel Warshevsky, who have been with us for a long time over and over, and Dr. Liz McGow, who's able to come back. Next slide. And Dr. David Kaplan, who's also able to come back. Next slide. So I'm going to turn it over to each of them one at a time to introduce themselves. Nicole?
Hi, good morning. Nicole Blackman from the Indigenous Primary Healthcare Council, as mentioned. I have no conflicts of interest to declare, but I do have an affiliation of employment with the Indigenous Primary Healthcare Council.
Allison.
Good morning, Allison McGeer back from Sinai Health System, and congratulations on 50. As you see, I do a lot of work with both vaccines and therapies for COVID, and have relationships with many commercial ventures. Thanks.
Dan.
Hi, good morning, everybody. Daniel Warshevsky. I'm, as mentioned, Associate Chief Medical Officer of Health in the Ministry of Health for Ontario, and no anything to declare. And 50, yay.
Liz.
Hi, everyone. Family doc in Ottawa and now employee with Ontario Health. And I have no conflicts to declare and just lots of feelings of celebration to gather with everybody again on this 50th momentous.
David.
Hi, I'm David Kaplan, family doctor in North Toronto and Vice President Quality at Ontario Health, and some disclosures, so honoraria for these sessions from the OCFP and salary support from Ontario Health.
Mahalay.
Hi, everyone. I'm a family physician. I practice in Cambridge, and I do receive a stipend for my role as president with the OCFP. I don't have any other conflicts to declare.
And I've introduced myself, and I've listed here some of the places where I get salary support and research grants and where I've gotten speakers honoraria. I don't think any of them pose a conflict for today's talk. Next slide. So of course, what makes these sessions special is your interaction. So please do put your questions in the Q&A box and put your comments, your resources, your thoughts, reflections into the chat. Next slide. Today, I just wanted to tell you kind of what to expect. We're going to start by having Nicole share with us some strategies to support vaccination uptake among Indigenous people here in Ontario and elsewhere. We are then we're going to turn it over to Alison McGeer, who's going to give us a bit of a review of where we are with COVID cases in Ontario, new variants, the new bivalent vaccines, and trying to break down and make simple sort of that fall booster approach. And then Dan's going to kind of piggyback on that and tell us kind of where we are at with actually delivering those shots now, and when we can expect things to come from a delivery perspective. And then flu shots, we're going to talk about that, Alison and Dan together. And then we're going to turn it over to Dan and Liz to tell us more about gaps in some of the routine vaccinations. Next slide. So without further ado, I'm going to turn it over to Nicole to get us started. Next slide.
Miigwech Tara. So good morning again. IPHDC was asked to come and speak to the work that we've done with regards to addressing vaccine hesitancy among the Indigenous population, focusing primarily on the wide practices for vaccinators webinar that we hosted. Next slide. So just to start, do you want to share that there is a significant degree of medical mistrust that many Indigenous peoples hold towards the health system, as well as the agents that work within it? Contributing factors include testing and medical experimentations that were done on children in both the residential school system as well as Indian hospitals. And the degree of medical mistrust was particularly evident by the vaccine hesitancy that we saw when the population was prioritized for the COVID vaccine, with many believing that they were being tested on for the new vaccine. Next slide. Indigenous health and Indigenous hands addresses medical mistrust at some point, as some Indigenous people feel safe accessing Indigenous-led programs and services. So some strategies to incorporate Indigenous health and Indigenous hands within your practice, maybe to explore integrated care that is inclusive of the model of holistic health and well-being, understand the value and necessity of traditional healing when supporting Indigenous clients, support the concept of culture as healing, and look to develop referral processes, so to work in collaboration with Indigenous primary healthcare organizations, where you're able to offer both a blend of Western and traditional medicine in order to meet comprehensive Indigenous health needs. Next slide. So last fiscal, the IPHCC developed a strategy to support Indigenous participation in the COVID-19 response. And while the content is COVID related, the concept of the engagement can be applied more broadly. We provided a link in the deck for those who are interested in completing the 30 to 45-minute course. Next slide. And as mentioned, IPHCC hosted 2 wise practice webinars in collaboration with OMA, with the purpose of providing healthcare providers the foundational knowledge required to support vaccine administration among the Indigenous population. Next slide. Some of the wise practices that came from the webinar is to strengthen your knowledge. So keep learning about Indigenous communities and colonization, learn more about why Indigenous peoples are hesitant to both self-identify as well as get vaccinated. Be aware that some Indigenous-led clinics may smudge as a supportive practice. So if working in partnership, to be aware to expect, as well as build your understanding of cultural safety and what it looks like within the context of COVID and vaccine hesitancy. Next slide. The next wise practice is to scrutinize power. So recognize that power differentials do exist between patients and healthcare providers, and it's really important to build trust. Consider your body language when providing vaccinations or any other supports in terms of not standing over, but more being at the same eye level. Take time to generally address concerns about vaccinations. If they've made it to your door to discuss, that is a big, significant step. And speak up when you see or hear something problematic. Had the student nurse who was working with Joyce Eshkwan spoke up, felt safe to speak up when the nurses were making racist remarks. There might have been a chance that she'd still be with us today. Next slide. As well as look at unsettling privilege. So be reflective in your own position and intersecting identities, explore your own bias and assumptions, explore other ways of knowing and healing approaches to healing, to be reflective or mindful of the importance of traditional healing and culture of healing, and advance cultural safety within your practice whenever and wherever possible. Next slide. So some key takeaways are that it's critical to understand the colonial history of this land and the ways in which the health system as well as the agents that work within it are involved. Understand that power dynamics do exist within the system, and as a vaccinator or as a service provider, it's important to be mindful of the dynamics and ensure that you're working to build trust with your patients and clients in order to create a safe vaccination experience. Next slide. As well, one of the main things that we heard when COVID materials were being promoted was that Indigenous peoples didn't see themselves in the resources that were being put out by mainstream. So IPHCC developed a number of social media posts, and we continue to, with varying information that we'd be happy to share. Next slide, please. We also developed fact sheets and most notably informing the population why Indigenous peoples were prioritized for the vaccine. And again, we'd be happy to share those. Next slide. We also have a number of video projects that are either completed or in development in which Indigenous healthcare providers answer questions, or those with lived experiences share about their vaccine decision-making journey. And we're partnering with Indigenous TikTok influencers in order to target youth and young adults. Next slide. And lastly, for those interested in taking ICS, we do have the first course in the Anishinaabe-Minoayoan People in Good Health approach to ICS available. With the link above or circled above to express interest. Next slide. Miigwech, and thank you for your time.
Thank you, Nicole. That was a great summary of, I know, a lot of work that could also take a lot longer to get into in depth. And so just wanted to flag for everyone that you know, I would encourage you all to do the Wise Practices webinar. I think the Wise Practices webinar, the recorded session, but also let us know afterwards. We're going to put into our evaluation whether you would like to have a more in-depth session. And if so, then we can organize that together with Indigenous Primary Care Council. So I'm just going to, I know that there's been a lot of questions and answers already being asked and answered, but maybe at this time, what I'll do is if there's more questions for Nicole, please do put them into the Q&A or to the chat, and then we can address some of them. And then I will be going to Dr. McGeer soon. I noticed one question that's already come in that maybe I could ask you, Nicole. So Indu Gambier asks, how can we talk about the Inuits' need in this area? And I think if I remember correctly, she probably works in Ottawa, where I think they do serve an Inuit population very specifically in the clinic she works in, I think.
I think the most important part would be to connect with TI as well as Inuit associations in Ottawa and surrounding areas to kind of get a sense as to what it is that the vaccine rates are looking like and strategies to address more. We do try to incorporate an Indigenous component into the work that we're doing. We have a knowledge keeper circle where we have Inuit youth and elders sitting on, But I do think that that's the most appropriate approach, is to explore collaboration with PI as well as Inuit associations in your local areas. I'd also say don't assume that you have a small Inuit population, as well as really look to see what your size is in your community as well.
Yeah, I think that's a great point, especially since many people don't want to self-identify as Indigenous or as First Nations, Inuit, or Métis because of fear of discrimination and racism, which I think Janet Smiley's work has shown pretty clearly as well. All right, so I'm going to turn it over next to Alison McGeer, who's been she and Dan have done an incredible job already answering many questions in the chat, but I know she's going to actually speak to some of those very directly. So Alison, I'm going to turn it over to you.
Thanks, Tara. Sarah, there's my video coming in. A little slow this morning, probably my brain and my video. Okay, so let's start with Ontario COVID activity. You can look at a number of different parameters, but I think the most important one to keep in mind is just where we are with severe disease and COVID. And this is the, COVID is not yet over problem. We're currently running about 50 deaths a week. The data for this last week are actually 61. A little bit of concern that it's ticking up. What that translates to over a 1-year period is that COVID, it causes twice as many deaths as influenza and ends up across Canada being the 7th leading cause of death. So it's when we talk to people about vaccines, when we think about what we're doing for the winter, it's important to remember that although COVID is like infinitely better, there's still too many people dying from COVID, and we still really need to keep working on getting people vaccinated and protecting the vulnerable among us. Next slide. Okay, so the next question is this rate going to change? And the correct answer to that is we really don't know. There are a couple of things that are making people a bit anxious. So on the top left of this slide, you can see the overall Ontario wastewater signal, and you can see that it's ticking up just a little bit, not dramatically. And if you look at the bottom left, the hospital bed occupancy and the hospital bed occupancy is flattening. And so when you look at all of the COVID parameters that you can look at in Ontario, we're no longer decreasing, and there are a number of them that look like they're ticking up. So people are a little bit anxious that we're going into a wave of more activity. Next slide. And these are from Our World in Data, just looking at hospitalization rates in different countries. And this is, the marker that there are a number of European countries where hospitalization rates are ticking up again. Again, not dramatic, not anything like as high as the summer wave of activity was, but just a marker that as booster protection wanes, as we go into the winter, now that schools are back in, it looks like activity is increasing again. And another good reason why we need to be out trying to get people to get their booster doses to make it a quieter season in hospitals. Next slide. Okay, what's coming in new variants? Well, that there's a lot of agonizing among virologists and epidemiologists about the variants. You can see this is a phylogenetic tree. And the red and orange variants are the variants that look like they have a growth advantage over BA5 and might be taking over. And you can see here that most of them are either descendants of BA5 on the left or descendants of BA2.75 on the right. And there's ones that people are worried about in both of those. And in fact, the new one this week, okay, is called XBB. When you see variants, names are getting really stupid, okay, granted. When you see a variant that starts with an X, that means it's a recombinant. And XBB is a recombinant of BA5 and BM 1.1, of BQ 1.1, which is something from BA5, and BM 1.1, which is something from BA2. However, let's be really clear. All of these are single digits. There's no consistent increase. And what people are really worried about is that Pi is going to come, right? So after Omicron, the next variant is going to be Pi. And it is important to remember that last November, Omicron came completely unexpectedly out of nowhere and is very different. And that, of course, is what everybody is really worried about. That if this is what is going to happen to the evolution of Omicron, that's okay. Next slide. And it's substantially okay. I know this is really confusing, but I just want to look at the groups of colors. One of the nice things about Omicron is that we're getting what's called convergent evolution, which is that although there's a lot of mutations, many of the new lineages are getting the same immune evasive mutations. And that kind of suggests that maybe there's a limit to how far Omicron can go and how distant it could get. And that's really reassuring. So I think the consensus is if we're just getting Omicron variants, it's probably going to be okay. The real concern is if Pi comes out of nowhere, and there's no way of knowing whether that's going to happen, and thus really no point in worrying about it. It's just, let's focus on trying to protect people from Omicron. Next slide. I know, and I put that slide up because it's just so busy, but it blows you out of the water. Okay, so one of the challenges is that, as we get more vaccines and things get more complicated. So this is just a quick review of NACI recommendations for healthy children and adolescents, because Dan is going to show you some slides about how far behind we are with getting children vaccinated. So NACI for 6 to 59 months is still a May recommendation, and it's 2 doses of Moderna. Pfizer is coming for younger children, but not here yet. For 5 to 11-year-olds, it's a should from NACI, indicating that NACI is confident in the decision that vaccine is better for you than not being vaccinated by a significant margin. And Pfizer is preferred because of the risk of myocarditis, even though we know that risk is lower in 5 to 11-year-olds than in adolescents. And 5 to 11-year-olds may get a booster. At the moment, the Pfizer 10 microgram dose is preferred for the booster over the bivalent vaccine. 12 to 17-year-olds is a should. Pfizer preferred and Pfizer preferred. The booster is a may, and Pfizer preferred for the booster. Next slide. Okay, NACI recommendations for fall boosters at the moment. Okay, and I think this actually might be changing today, but certainly will likely be changing as other bivalent vaccines become available in the next few weeks. But here we are for the moment. Okay, so 6 to 59 months. No booster recommended at the moment. Healthy 5 to 11-year-olds and 12 to 17-year-olds, the booster recommendation is a May, and it's Pfizer original, not the Moderna booster. In 12 to 17-year-olds who are at risk, and there's a long list of at-risk conditions, anything that increases your risk of COVID, anything that increases your risk of complications of COVID, and Pfizer is again preferred, but either Moderna vaccine, either the original or the bivalent, is also acceptable. 18 to 64-year-old low risks, that's how may receive the booster, Moderna bivalent preferred, and 18 to 64-year-olds at risk, and everybody over 65 is a should, and the Moderna bivalent preferred. And everything now contains everywhere this 6-month, 3-month recommendation, which is 6 months if COVID activity is low, 3 months if you're particularly at risk or COVID activity is increasing. And what that translates to for now is that if you're more than 3 months after your previous booster or your infection, that you should be getting the may or the should, depending on who you are, be getting your fall booster. You will still occasionally run into, I think, some pharmacists and some other providers who want to hold out for the 6 months. And that's, the only, I think, good news about the complexity of vaccines at the moment is that it's a marker that the decisions are less important and the vaccines are less urgent. And that is good news. Next slide. Okay, so why get a booster dose this fall? Really simple, okay? It is now like getting vaccinated against influenza, because COVID is still worse than influenza, but no longer dramatically worse than influenza. So if you're over 50, it reduces your risk of death. If you're any age, it reduces your risk of hospitalization and illness and post-COVID condition. It reduces the risk that you will transmit it to other people. And this winter, it will help our healthcare system provide care, not just for COVID, but for everything else in the system, and help us catch up on the prevention and management of illness that we've fallen behind in. So lots of good reasons. In terms of talking people into it, which is getting increasingly difficult, I think there's three things to remember. The first is there's no miracles in getting people to get vaccines. It's about building trust with them. It's about talking to people. It's about all the little things that you can do to support people making decisions. It's also about bringing up vaccines at every interaction with people. And it's about using presumptive language. When people come into your office, when you're talking to people, assume that they're going to get the vaccine. Don't say, are you thinking about getting the vaccine? Say, have you had your vaccine yet? You know, is there something I can help you with making the decision about the vaccine? So always assume that they know that you know that they should be getting the vaccine and that they're going to get the vaccine. They may just need help with it. Next slide. Okay, just a quick note, because this is a new systematic review out this week in JAMA Pediatrics for people talking to pregnant women, looking at outcomes of vaccination during pregnancy and identifying that pregnant women who were vaccinated, babies were less likely to be admitted to the neonatal intensive care unit. They were less likely to suffer intrauterine fetal death. And in women who were vaccinated in the second and third trimester, a lower likelihood that there would have preterm births or babies who were small for gestational age. Those look like pretty small odds ratios, but for pregnant women and for those people who care for pregnant women, those are big differences in terms of fetal outcomes. So another good reason to be really working at improving our vaccination rates in pregnant women over the winter. Next slide. Okay, so what do you get out of a booster dose now? And the important thing that you get out of a booster dose, besides like not getting sick and feeling miserable when you're supposed to be at work or at school, is reducing the odds of hospitalization. And this is a research letter from looking at the odds of hospitalization of 3 versus 2 doses. It's important to remember that 3 versus 2 doses in healthy adults, which is mostly what this is, younger adults, is the same as 4 versus 3 doses in us older adults, because we don't respond as well to vaccines. And given the shift to BA.5, you also need extra doses of vaccine to account for the immunization. So this, to my mind, is very close to the benefit that we're all getting out of a booster this winter. And what that translates to for the first 100 days, so that's October, November, December, and the first couple of weeks of January, is a 60 to 67% reduction in hospitalization. It's not 100%, okay, 100% would be nice, but 67% is a really big reduction. And so what you get out of a booster is a very significant protection into January. And in January, we can make decisions again about whether people need boosters or what's going on. We can all hope that, you know, nothing's going to change with BA.4/5 and everything's going to calm down and January will be okay. But if it's not okay, we get to make decisions about boosters again. And in the meantime, the booster that you get now is going to protect you well against hospitalization through to January. Next slide. Okay, the big question is different protection with different boosters. And it's really hard and complicated, and I'm trying to make a simple slide, and I have completely failed. But what's important here is that the different booster doses are all up in the top left corner. So the blue and the orange and the red and the brown are the ancestral vaccine, any bivalent booster, the BA.4/5, the BA.1/2, and they are all very different from the gray, which is no booster. Okay, what that tells you is, to the best of our knowledge, it actually doesn't matter very much which booster you get. Even the ancestral booster is going to give you a substantial increase. And in particular, it tells you that you can see the difference between the blue, which is the ancestral boost, and any of the variant boosters, but it's really hard to tell the difference between the different variant boosters. When you layer on top of that, we're going to end up with probably a Pfizer BA.4/5 booster and a Moderna BA.1/2 booster. But remember that Moderna gives you higher antibody levels. Okay, so there's almost certainly it's going to be something very close to a wash between the Moderna BA.1/2 and the Pfizer BA.4/5. And again, you know, what we really want is people to get a vaccine. And if people prefer to get the Pfizer vaccine, that's okay. But it's really important that people who got the Moderna vaccine are going to get it before Pfizer's available are not regretting it. There's absolutely no reason to think that the Moderna BA.1 variant vaccine is not going to give you as good protection as a BA.4/5 vaccine. And just in the bottom, you can see this is from David Coury and Deborah Cromer's group in Australia, who are the people who know the most about the translation between immunogenicity and protection. And their estimate is that the biggest difference in hospitalization between the variant vaccines is less than 1%. So we're talking about a difference between 92% protection and 91.2% protection. And the biggest difference in protection against any illness is 6 or 7%. So really doesn't matter which booster you get. The other nice thing about that is what it tells you is if you're giving out boosters to adults, you can't make a mistake. Okay, doesn't matter which vaccine people get, doesn't matter if they got the one they didn't intend to get, as long as they get a booster, it's okay. Next slide. Okay, and now the next question is, you know, people think, well, if we're just going to have BA.5, then it's better to get a BA.4/5 booster. But the truth is, we don't know what we're going to get from Omicron. And looking at this, right, the BA.2.75 and the BA.5 both look like there are new variants coming. So, you know, if the BA.5 variants continue to take over, well, maybe a BA.4/5 bivalent vaccine is a little bit better. But if the BA.2.75 variants take over, which they might do, then maybe the BA.2 variant is going to be the better vaccine. There's really just no way of knowing. And once again, it's just any booster is fine. Very little difference between them. Next slide. Over to Dan.
Okay, thanks, Allison. So Allison did all the important stuff about what we know, but now I'm going to give just what's happening right now in Ontario in terms of our COVID vaccination. So if we go to the next slide, please. And so, sorry, I know this is, again, a pretty busy slide, but I think really important to show what our coverage rate is like right now for booster doses, given how important Allison was just saying everything is. And the overall answer is that it's pretty low. So this is, you can see by each public health unit and then Ontario as a whole. The way we're assessing boosters right now, given the data limitations, is just who got a vaccine since September 1st as a rough one. We do know, obviously, that there's lots of reasons you might not have. You just had COVID, you got one in the summer, and so you need to wait a little bit longer. But generally speaking, that's going to be more useful indicators to go forward for the season. And you can see our intake, our uptake right now is quite low across all populations, with a total, even for the highest risk groups, such as 11% of individuals 70 plus having received their fall booster dose. So coverage is quite low. Even by health unit, the very highest is still not even breaking 20%. And again, that's the highest risk population that we're seeing, that's 70 plus. So again, we don't know exactly how many people had infection and how many are waiting because of that 3-month to 6-month interval from the last infection. But I think, safe to say that even with what we expect with the infection rates over the summer, we're probably still quite low in terms of people having coverage and good protection against the fall wave that we do expect to be coming, and are just seeing the trickles of it starting to increase now. If we can go to the next slide. I did want to speak specifically about our pediatric and infant coverage for the primary series. This one we have had a lot of difficulty in Ontario. We're lagging behind most other provinces as well in terms of our primary series uptake for children under 5. You can see that Ontario average is 6% of children under 5 have gotten their primary series of the COVID-19 vaccines, which is pretty abysmal, and I wish we were doing better. There is a huge variation here by public health unit that we've seen, bigger than what we see for the other age ranges. Ottawa's at the top at 14%, which is great, but still a lot of room to go. And then down near the bottom, we see a whole bunch of health units just around 2%. So a huge area where we could really see some improvement in getting protection for this group, especially since we do know that the youngest children, particularly those under 2, are at higher risk of severe disease and hospitalization from COVID-19. If we can go to the next slide, please. And this is our 5 to 11 coverage. And I think David Kaplan was putting in the chat some of the numbers around this too. This one I think is really interesting for a number of reasons. One is, we hit that 55% coverage for first doses relatively early on in the program when 5 to 11s were first able to be vaccinated. And it's been trickling up since then. So that would have been, about 9-10 months ago when it first opened, and we're now at 59%. So that's like maybe 5% in the last 9 months have additionally first doses. But I think the really important note is that even completing the primary series is a struggle, because we see a 20% drop off between first and second dose. So only 39% of 5 to 11-year-olds in Ontario have actually gotten their second dose and completed the primary series. Again, this isn't something we've seen with other populations and age groups. Most people who've gotten the first dose have gone forward to complete the series entirely. But for whatever reason, for 5 to 11s, we're really just not seeing it. Probably a combination of many people had COVID, and people are seeing their 5 to 11s don't get very sick. But it is an area where we could see a lot of improvement, again, particularly as we get into the fall. And you can see in the final column is who's been able in the 5 to 11s to get their booster dose. Obviously, it's extremely tiny given what the coverage was for the first 2 doses, but an area of much improvement that we can have as well. If we go to the next slide, please. And so this is just quickly, and I don't know if Liz was going to speak to it or if I was, but I can talk to it anyways, about the Moderna Spikevax bivalent booster and the current recommendations in Ontario. Obviously, these are based on the NACI recommendations, as Alison's already gone through. And so the recommended interval is 6 months with a minimum of 3 months. Generally speaking, anyone who is high risk should be coming for that shorter interval to get that protection sooner before we really get into the midst of the COVID-19 season. It's 65 and over now, so sorry for the apologies on the slide, but otherwise it's really those high risk groups, 65 and over, long-term care homes, retirement homes, Indigenous populations, anyone who is immunocompromised or has significant underlying medical conditions. The one particular note is the 12 to 17 here, which Alison mentioned as well. The product is only authorized by Health Canada for 18+, but NACI has an off-label recommendation for immunocompromised 12 to 17-year-olds because of the significant risk that they have of severe disease, that they can get the Moderna product now. So that's who we're really recommending strongly to immediately come forward to get vaccines. But of course, everybody should be coming to get their fall booster if they haven't had it yet. Next slide, please. I think you want to pause for a bit now, right, Tara?
I think we're going to pause and do some questions and answers. Now, I think you and Alison have actually addressed a lot of them, but I just I wonder, Brian, if we could just go back a little bit to Alison's slides where she had the table of fall boosters. And I just wanted to, Alison, reinforce actually, first I'm going to ask you the question that I think there's some confusion over, and just if you could restate it, is the interval for when you want to give the vaccine. So there's the amount of time after you've gotten your previous dose of vaccine. And so we understand that it's either between 3 months or 6 months. And then there's also after infection, when you get your vaccine. So maybe Allison or Dan, if you could clarify that for folks.
Allison's still getting off mute, so I can start. But yeah, so the intervals for either previous vaccine or infection are the same now. Recommended is 6 months, other than someone who's high risk, or if there's high risk from the epidemiology. And to Allison's point, we're expecting things to keep going up in the near future, in which case the 3-month interval will be recommended, so you'll have the protection they need prior to significant circulation of COVID-19. Sorry, okay. Allison, you're off mute now.
Yeah, no, that's exactly, Emma. This is Dan is the voice of authority here. I do think, you know, there's nothing wrong with younger people at the moment holding out for a little bit longer. I think people also might want to think about, so I got my booster dose in part because I had to go to a meeting in Europe, and, you know, air travel, international air travel is right at the top of the list of risks. So that's a good reason to get, you know, any kind of international travel is a good reason to get a booster a little bit earlier. So, you know, I think it's fine for people to be making choices at the moment. I don't think it's not been a big deal that people have not gotten their booster dose in the last month. What's making us all nervous now, I think, is the fact that we are seeing an effect of what looks like the fall. Is not new variants that are causing a problem. It's just like the beginning of the fall wave we were accepting. So, and, you know, flu and RSV are coming. And so any of us who I think work in healthcare are starting to get anxious about what trend is going to happen, and that and we do, there's a lot of vaccines to deliver. I'm really hoping that the concomitant flu and COVID vaccine, I'm sympathetic to people. I have to say, when I went to get my vaccine, it was kind of like, oh, yeah, I got to trek all the way over to the Western and get my vaccine. It's a pain in the neck, even though I have to do it. So I'm really hoping that, you know, we know that, you know, 75% of older adults are going to get their flu vaccine automatically. And if we can persuade all of us to get our flu vaccine and COVID vaccine together, that will really help with both the efficiency of the program and making sure that people are protected against both diseases.
Great. And then I wonder if you could just reinforce sort of this issue related to younger adults and the choice of Moderna and Pfizer and the risk of myocarditis potentially with Moderna, and how we should be counseling patients in terms of, I think you had a really clear benefit slide there, Allison. I don't think on the benefit slide, somebody pointed out, I don't think the benefit was that it would protect you necessarily from getting infection. It would protect you from getting a more severe infection. And so I think just if you could clarify that, and then also clarify, you know, that the potential risks and the benefit outweighing the risks for which vaccine and which group, for Moderna specifically, I guess, for the youth.
Yeah, so I think the difference in NACI recommendations and it being more liberal with saying that younger adults can get Moderna is because there are increasing data that booster doses are less associated with myocarditis than the original series, so first and second doses. So you'll notice that NACI is now recommending Pfizer preferentially for people under 18, because the highest risk, right? Remember that myocarditis is younger people and men. And so we're still suggesting that people who are under 18 and are healthy should not get a Moderna vaccine. Pfizer is preferred. But NACI has now looked at the data on myocarditis and says for booster doses, if you're over 18, it's fine to get Moderna.
Okay, that's helpful. And so there's this question that keeps coming up about waiting and counseling patients who want to potentially wait for the BA.4/5. I think you presented some compelling evidence that BA.4, the BA.4/5 specific bivalent vaccine isn't something you should generally be waiting for, because it's generally going to be fairly similar in the way that it protects you. But it sounds like there are some specific groups if you're under 18 where you would, well, actually under 18, you're not going to be getting the bivalent. So maybe Allison, just clarify for us this issue of counseling patients who want to potentially wait for BA.4/5.
You know, I think there's some patients who are just bound and determined to wait for the BA.4/5. We've in my view created a monster about BA.4/5 vaccines, and I think it's come from it's come largely, I think, from the United States, where it's been much harder to persuade people to get vaccines, and I think public health people were really hoping that it would be easier to talk people into a bivalent BA.4/5 vaccine, and so they just went with the flow, even though it just really doesn't matter. So to me, the most important thing is people just getting their booster dose of vaccine, and I wouldn't waste much breath trying to talk people out of the BA.4/5. I think it's coming fairly soon, probably weeks, and so I'm completely happy with advice that says, really, I think you should just get your Moderna vaccine now. I think it's going to be as good, and I'd like to see you protected as cases start to go up over the next month. But if you want to wait for your BA.4/5, that's good. Just remember to get it as soon as it comes. And maybe, please don't complain to me if there's an overwhelming demand for it and you have to wait an extra couple of weeks in order to get it. If people want their BA.4/5 vaccine, it's fine. It's just that.
And I guess there's the group that's like 18 to 30 who are men. Would that be a group that you might suggest needing to wait? So I'm paraphrasing questions here that are coming about, those 18 to 30 who before that was a recommendation to avoid Moderna. You talked about how the booster doses are safe, give less myocarditis, but then how about this bivalent vaccine, which is Moderna?
So NACI's very clear that as long as you're over 18, that the Moderna is fine and you don't need to wait. But again, if people are anxious, I think we're at the stage. Well, I'm hoping we're at the stage that the supply of BA.4/5 vaccine is coming soon enough that if people are anxious, it's okay for them to wait.
Great. And then, of course, for the kids, the vaccine that's available is the original strain, kids and most teens. Is that still? Can you speak to the protection that's still potentially offering them, given that it's not the new strain?
Yeah, so I think you want to go back to that slide. That the differences between ancestral and bivalent are small, okay? Not zero, okay? It's like if you get a choice, bivalent's a little bit better, but really the difference is small. And even ancestral boost is very close to the bivalent boost. It's not. I think we've gotten so used to this intense focus with flu on we need to match the flu strain that we think we have to match the COVID strain, but it's not true. Okay, COVID's a lot like flu, but it's not flu in a number of distinct ways. And one of those ways is that you don't have to match the vaccine to COVID the same way you have to match vaccine to flu.
Thanks, Allison. So I'm going to ask a couple more questions here. So Peter Suckles builds on your first slide, Allison, that you said that COVID death rate is 2 times the influenza death rate. But what is the COVID hospitalization and death rate among people who are fully vaccinated 3 doses compared to influenza?
Off the top of my head, I can't tell you. I mean, I think it is absolutely true that it is still people who are not vaccinated or under-vaccinated who are at higher risk. But it is also true, remember, almost all of us, particularly almost all of us older adults, have had 2 or 3, the majority of us have had at least 3 doses of vaccine. Most people in hospital now have had 3 doses of vaccine. Some of them have had 4 or 5. Your protection, even after 4 doses or 5, if you're immunocompromised, protection against hospitalization wanes over time. My guess would be that if you've had 4 doses of vaccine, if you're not immunocompromised, or 5 if you are, that your risk is still a little bit higher than your risk of influenza if you're vaccinated. But I would have to run the numbers, don't know.
So I think there still seems to be confusion among people about, who is eligible when, and I just would encourage folks to take a look at those slides again and maybe even rewatch Allison's talk. And we'll try and also share some resources that clarify this so that you could have on your quick resources to kind of understand that. I'm gonna just change tacks a bit and ask Allison or Dan, is there any update on the Paxlovid guidance? We have Suzanne Singh says, we have patients who are vax ×5 that are older adults who ask about Paxlovid eligibility.
Yeah, I can start. I'm so specific to the guidance. It is being worked on to update, given that it's been, I think maybe the late spring was the last time we had an update from the Science Tables Therapeutics group. So things are coming. I think the data that we've seen since then, and Allison, please jump in, continues to show that Paxlovid is a pretty effective product at reducing hospitalization across the board, even in people who have been vaccinated. So at this point, individuals who are really very high risk for hospitalization, even if they've gotten 3 or even 4 vaccines, it's something to consider. So that immunocompromised population, people with significant medical comorbidities, to consider as well. But the guidance is still pending, probably be another month-ish. So sorry.
Thanks. So Brian, I'm going to ask you to pull the slides back up, and maybe we'll just switch gears to the flu shot right now. I guess as we're doing that, Allison, one question for you, just as we're doing that, is people have been asking about PPE, and maybe you could just re-review, in the clinic, what we should be wearing even when we're seeing asymptomatic patients.
Yeah, so I think, what's important, right, are distance whenever you can, hand hygiene, and masks in that order. And after that, then the questions are, is anything more important? There is a possibility that face shields will help to improve your protection if you're up to somebody. I don't think there's any evidence that gowns or anything added to that will make a difference. So I think masking remains critically important for all of us in healthcare. You know what I'm going to say about hand hygiene. Okay, this is your mother speaking. Hand hygiene, there is really good evidence that hand hygiene prevents all sorts of infections, and is really important. And I think wearing a face shield is a reasonable choice, but probably not essential in those of us who've been vaccinated and are willing to accept now some small risk of getting COVID. More than that, and any distancing that you can manage without interfering with care is a good thing. Beyond that, I don't think you need more.
And just to clarify, N95 or surgical mask or either?
It is, the recommendations are N95 respirators. I still believe that the real benefit of masks is source control, right? So the greatest benefit of masks is when they're worn by the infected person, not when they're worn by the exposed person. So the critical issue with masking is that all of us in healthcare situations are wearing a mask. I think with Omicron, there is evidence that in people who are exposed, wearing a respirator has some increased benefit. And so I think if you're if you're comfortable in a respirator, then respirators are probably a bit of an advantage. But I'm not going to insist that you wear a respirator. There's also a difference between N95 respirators and KN95 respirators in the quality of the filter of some of them. So if you want absolute best protection, N95 respirators. But I'll buy you wearing a mask or a KN95 respirator as adequate protection at the moment, as long as you're up to date with your vaccines.
Thanks. All right, so there is lots of questions about co-administration of flu and influenza vaccine and timing. I know you're going to get to that, so I'm going to turn it over to you, Allison, to start, and Brian, maybe you can go to the next slide.
Okay, so here's the latest co-administration data. There are a couple of randomized controlled trials that are a bit smaller than this that show the same thing. So on this slide, the darker blue is Pfizer, the darker yellow is Moderna, and the lighter is the two vaccines, so COVID and flu given at the same time. And what you see fairly consistently is there's a little bit of an uptick, bigger with the Moderna vaccine than the Pfizer vaccine in reactogenicity. So pain at the site, redness at the site, any systemic thing like fatigue, fever, not able to adequately do activities of daily living in the day or two after you get the vaccine. So when you get the two vaccines together, there is a significant, in this study with tens of thousands of people, but small increase in reactogenicity that people need to know about. This study does look as if the difference is a little bigger than the randomized controlled trials. And that's because this is an observational V-safe study. So people knew they were going to get concomitant vaccine and they got told there was going to be an increase in reactogenicity. And of course, if you're told there's going to be an increase, then you notice it more, right? So the difference is actually probably a little smaller that's on this. But really the most important thing is when you get down to unable to work, or needed medical care, there are absolutely no differences. A little bit of increase in reactogenicity that people need to know about, but absolutely no reason why you can't get a COVID vaccine and a flu vaccine at the same time, except that then both your arms might be sore for a day or two. And so this is a really good opportunity, I think, when there's fatigue setting in, to get people to get both their COVID and flu vaccines at the same time in clinic or in pharmacy. Next slide. Okay, so the other thing that's different this year in Ontario with flu vaccines is that this year, for the first time, we're getting adjuvanted influenza vaccine for older adults as well as high dose. And the reason for that is that what we had up until a couple of years ago, the last time there was flu, okay, we had a randomized controlled trial for high dose vaccine and some not great observational data for adjuvanted vaccine. And so NACI said, you know, if you're going to give an enhanced vaccine to older adults, the evidence is very clearly better that high dose vaccine is better, and we're not sure about adjuvanted vaccine. In the interim, however, what we've seen are US observational data about vaccine efficacy comparing adjuvanted vaccine and high-dose vaccine in older adults from the 2017-18 and 18-19 seasons in the United States. And there, surprisingly, there was very little or no difference between the protection you got from adjuvanted vaccine and the protection you got from high-dose vaccine. So it's a dog's breakfast, okay? There's a lot of different data, and most of it is observational, and it's really hard to know where it's going, and it's only for mostly one season and a little bit of two seasons. But The end of it is ACIP has completed their review. So the CDC and the American group has completed their review, and NACI is finishing their review. So we should hear from NACI soon. And the American review says that consistently, the data says that enhanced vaccines are better than standard dose vaccine for older adults. But at the moment, it looks like adjuvanted vaccine and high dose vaccine are equivalent. So the message is that for older adults, either adjuvanted vaccine or high dose vaccine this year is fine. And again, it's better. And so if you can get an enhanced vaccine for somebody over 65, that's great. But if you think you're going to lose them and they're not going to come back, or they only want standard dose vaccine, or all you can get is standard dose vaccine, that's still a lot better than nothing. So the good news is that there's probably going to be less agonizing over the supply of high dose vaccine, because we'll have more adjuvanted vaccine available this year. And this is for this year. And next year, we'll take another look at the data and make a decision about what the recommendation is next year, because it may change depending on what the data look like year over year. And then back to Dan, I think.
Yeah, we'll go to the next slide, and that will be Dan.
Yep, so I'll go quick here. This is just to give what products we do have currently in Ontario. I should say currently, as in will be available for the flu season now. In terms of supply that's in Ontario, and I'll get to the next slide in a second, it's really just the initial supply that's come in, really for the highest risk populations in long-term care. But you can see we have a number of products. Not that anybody ever asks about what flu product they're getting when they come in for their flu vaccine. It's just a COVID thing. But if there are questions, these are the ones that we do have available broadly, and they just have different age indications primarily in terms of who can get them. So the only ones for 6 months and older are the Fluvaval Tetra and the Fluzone quadrivalent. So for the 6 month to 5 year olds, it would have to be one of those products. As Allison said, the enhanced products, so the high dose and the adjuvanted, are for 65 and older predominantly. And then for the rest of the population, we also have the Afluria Tetra that's in pharmacy, or the Fluvaval and Fluzone would be ones that you can have in your clinics that you can offer to anyone over the age of 6 months. Next slide, please. And so this is just a really brief thing on the timing of the rollout. So as I mentioned, we did get the initial supply in of the first highest risk populations flu vaccine, so the high dose and adjuvanted that have come in for hospitalized patients and long-term care home residents. And so that's gone out to public health units and available to be given out through those two settings already. The rest of supply that comes in for the first bunch of the high-risk population, so that's, and I have the next slide to quickly go over it, but mainly older individuals and those with medical comorbidities, is coming in right now as we speak, and will be distributed shortly, and so going out to pharmacy and primary care. And then it's November when we have the final supply to be able to go out to the general population as a whole to provide flu vaccine. And so the next slide, quick, I don't have to talk through it, but just a quick reminder of who is high risk. We're all very familiar. I think this list is pretty much the same high risk list as for COVID, other than the kids under the age of 5. But these are all individuals who are high risk and recommended to get that flu vaccine as soon as possible, and particularly for those who are eligible for the high dose and adjuvanted to receive one of those enhanced products. And I'll just quickly emphasize again, you do not have to have any wait between flu vaccine and COVID vaccine. It can be done at the same time. We really want people to have the protection.
And is that true the same time even in pregnancy?
All the data I've seen shows that still stands up for pregnancy and any other condition. Allison can jump in too. And to clarify for the kids under 5 around the vaccine, the NACI recommendations are to prefer an interval of 2 weeks between COVID vaccines and other vaccines if possible. That's not because of any identified or theoretical risk. It's for monitoring of our adverse events and for surveillance. So realistically, if it's going to impair the ability to get those needed vaccines into a child of that age, better to give it to them than to wait that full interval.
So the next slide, I don't know if you'll speak to that, Dan, but it's just to say that people should be getting some people have already gotten their flu vaccine in primary care, and they will be getting it shortly if they haven't. Is that right?
Yeah, exactly. So I think it's over 1,500 already received, but again, please just, if you haven't, go out and contact your public health unit, put your orders in, make sure that you can get it as soon as you get it.
Great.
Yeah, and I just going to put in a vote of thanks to the ministry and the chief medical officer about getting flu vaccine out early to high-risk people. So if you're having to wait a little bit in practice, it's because it's all going to long-term care homes, and so it's really nice to see it prioritized. And I thank you for being a little bit patient outside.
Next slide. So I'm going to just now also just talk about, I know we're going to run till 9:15 and that may leave us a bit of time for questions, but I just want to turn right now to some of the school-based immunizations as we're talking about vaccines. And I wonder, Dan, if you could give us an update on where we are at with some of the catch-up vaccines. So we'll go to the next slide, Brian.
Yeah, absolutely. Thanks, Tara. So this is for specifically the school-based administered vaccines. This is primarily done through public health units. And this is data of administered doses that we have. So thankfully, the doses given by local public health, we have in a single data system. So you can see here the difference in administration from 2017 to 2019, our pre-pandemic years, and where we've been at now in 2022. Obviously, in early part of 2022, we all remember it wasn't great. We weren't getting a lot of school-based vaccines given out. But we got pretty close back to parity over the spring months to what we normally administer. And I think the important thing to note is we're way, way higher now as the public health units are going through their catch up in terms of giving out the rest of the doses. So normally, again, July and August are pretty low months, but we had pretty good uptake as the catch up happens. The vast majority, obviously, of the school-based vaccines are given in the months that are just about to come, October, November, December, in the early part of the school year. So we're going to expect to see huge bumps there as well. And so catch up for these particular vaccines are well underway, and really hoping that by the end of this school year, everybody will have been caught up on the school-based program. If we can keep going to the next slide, I'll quickly, and the next one, sorry, speak to the routine childhood. This is a little bit more difficult in terms of the data, because it's only after the public health units complete their assessments of all the kids who are in school that we get the data on who has actually been administered the vaccine. And being only October, those assessments haven't been completed as of yet. But what we can show is basically ordering from all of you and from primary care through the public health units for all of the routine childhood series vaccines, which is what's on this slide here. So 100% lines, that dashed line you can see is the average ordering pre-pandemic. And so you can see we are getting the catch up done here as well. So thanks to everybody on the call for what you're doing and trying to catch up for all the kids who missed over the last 2 years. But we're seeing basically every vaccine across the board, particularly in the last few months over the summer and early fall, that we've seen significantly increased ordering, which we hope means significantly increased administration. The only one that is a little bit behind still is MMR. My guess is people are probably just giving MMRV instead to catch people up a little bit quicker, but this is a little bit limited data we have so far. We're hoping to have better data that we can share with everybody on where we're at in terms of catch up again in the next few months once those assessments have been completed.
Thanks, Dan.
But just a plug to get everybody all of their vaccines and up to date on everything, not just COVID.
So we can stop sharing, and I wonder, Liz, did you want to add anything to that?
I'll just emphasize what Dan said, and I think the challenge with these vaccines is that you really, like, a small dip below where we should be is really important in terms of risk for outbreaks of things like measles and polio, and we're starting to see that in the States. So amazing work, and the continued efforts to keep us, where we need to be for these vaccines, especially that it does, as Dan was saying, especially that MMR, the 4 to 6, and then Dan's data didn't include, the 14 to 16-year-old Tdap, and that's another one where we're lagging a bit behind on that. So, so keep up that work, and I think also the point that Dan made around the ideal of the distancing between what, Nancy said, the distancing between, routine vaccines and COVID is this 14 days, but actually, it's okay and safe to get them closer than that. So taking those opportunities to reinforce that message with parents is important too. So there are a lot of vaccines. I'm hugely sympathetic to the work that we're all doing to try to catch up on all of it. So, gratitude for that, and please continue that effort.
I guess one thing, Dan, I realized that I think we forgot to put the Evichel slide, perhaps, and you were going to speak to that. Do you want to speak briefly to changes in Evichel eligibility and access?
Yeah, absolutely. So Evichel guidance was updated earlier this week coming out of Ontario Health, and we can get the links in the chat for everybody. The main thing to note is expanded eligibility for two populations, one being individuals with primary immunodeficiency syndromes. With Scott Aldrich is kind of the one that we always, I think, first the list of examples, but anyone who has a primary immunodeficiency, and then patients who are taking B-cell depleting therapies for any reason. So many patients on B-cell depleting therapies for cancer treatments were already included in the previous eligibility, but this would cover now a host of rheumatological patients who might potentially be taking those particularly high-risk drugs and would now be eligible for Evichel as well. With that expansion, there's also expanded access to it. And I see David's popped up, it can probably speak to better than I can. But essentially, Evichel can be ordered now to access through community specialists, we expect mostly, but could be through primary care as well, to be administered in clinic for these two new expanded eligibility populations, since they wouldn't be going to either a transplant or cancer clinic regularly where they might have access to the products otherwise. And there'll be soon some additional access points in the community for specifically injection sites where people can come getting it, but that's still pending. But I don't know, David, if you want to add anything to that.
Liz, I don't know if you have anything. I was just going to post the different pathways to access.
Great. So there's also a couple of questions, like I think related to other kinds of flu vaccines that might be available privately and whether they have any additional benefits. So one also is, there's the nasal spray for kids, and I think there's a question about why that's not available, the LAIV, and then there's some other ones people have mentioned, I think Supemtech, I'm going to get the name wrong here, Supemtech, and others that people may be asking about. So I just wonder if you could speak to that, Allison.
Yeah, so I'm not sure whether nasal spray vaccine is available in Canada. The problem with nasal spray vaccine being available in public programs has been supply available to Canada, not that there's a problem with people not wanting to use it. It's just that there hasn't been enough supply for people to purchase it in regular procurement for publicly funded vaccines. And I'm sorry, I don't actually know whether it's going to be available in pharmacies this year or not. Do you know, Dan?
It should be, yeah, it's to supply, and there isn't enough for the public program. And to be honest, in the public program, when it was available, the uptake was tiny. But there should be supply available privately through purchase for a pharmacy.
Yeah, and it's not very expensive, or it wasn't very expensive when it was last available, so it should be fine. Two other vaccines for adults available in the private market. Supemtech is a recombinant, so it's made in a virus vector, and it's just the hemagglutinin. People were not actually expecting it to be better, but surprisingly, in the randomized controlled trials, it's done really well. So it will be interesting to see where it goes. There's no reason not to get it. There is not really strong evidence that it's better than adjuvanted or high dose, but it doesn't have the increased reactogenicity that high dose and adjuvanted have, right? So if you're an older adult and you get high dose or adjuvanted vaccine, you're more likely to get a sore arm. Turns out that most older adults don't care about it, but if somebody really wants a better vaccine and they're not willing to tolerate the sore arm, then Supemtech, if you can get it, is a reasonable choice. The other vaccine that's available and not in the public program are cell-based vaccines. And the advantage of cell-based vaccines is that, particularly for H3N2, when you grow a vaccine in eggs, when you grow a vaccine in eggs, when you grow a virus in eggs, it tends to adapt to the eggs, and obviously chickens are not humans. And so the adaptation tends to make it antigenically somewhat different than the virus you started with. And that in some circumstances reduces the efficacy of vaccines. So there, in some years and some circumstances, cell-based vaccines may be a little bit better than egg-based vaccines. They also have advantages in that you can turn on supply much faster, and you can make it in a shorter period of time than egg-based vaccines. So cell-based vaccines are where we're going in the longer term, probably. How much difference it's going to make depends on the year. And the availability. There's absolutely nothing wrong with the vaccine, but I think, you know, in Canada, we have public vaccine available, and for most people, you know, public vaccines are just fine and what we should reasonably be using. But either of those vaccines is okay if people want them.
Thanks, Allison. So Brian, I wonder if we could bring up the slide related to our poll. And just as Brian is going over that, I'm just going to remind people that the recording for this session is going to be available later today, and it'll be posted on our website. We also did have a session last time where Gerald Evans also went into more detail related to the bivalent vaccines. And so you may be interested in looking and watching the recording from the last session. I also want to note it's clear there's still a lot of confusion around boosters and bivalents and who should get what when. And I think we're going to take that back to folks and see if we can pull together some clearer resources for yourselves and for you to share with patients. So we recognize that this is not straightforward. You know, as we are heading into the fall, though, I think as Allison mentioned and others have talked about, we're of course worried about what the flu situation together with the COVID situation may bring us. And we wanted to better understand how your office is prepared. And we have two poll questions we're going to ask. So Brian, I wonder if you could launch the first poll question. So the first poll question is simply, are you seeing patients with respiratory symptoms in person? So the answer is yes, no, or no, but I plan to very shortly. And I think this is just, again, helpful for us to understand these are completely anonymous responses. It's helpful to us to just just understand how it's going for folks out there, and whether this is something also that we can try and support people with, either through policies, practical supports, or through our webinar, of course. Brian, are you able to screen share the results as they're doing the poll, just so we can see how many people have responded? Okay, Brian, tell me when, Brian, maybe you can screen share once you think that, okay, there we go. We've got pretty decent response. 325 people responded, and it does seem like 80% of people are seeing patients with respiratory symptoms in person, and with another 5% planning to this fall winter. There's still a significant number though who are not, and maybe we can add a question, you know, maybe you can email us, the OCFP or the DFCM, and let us know if there are ways in which we can support you to do that. And we can consider also putting in a question or evaluation about additional support. So let's go to the next question. Brian, can you launch the next poll? So the next poll is, what are the barriers to seeing patients in person, specifically patients with respiratory symptoms? What are the barriers to seeing patients with respiratory symptoms in person? Yes, Alan, none should be an answer, but if you don't have any barriers, you don't have to respond. Yes, we can always do better with our questions. Okay, Brian, why don't we display the results? Let's see. Okay, so yeah, I think space around physical distancing. We've got some issues related to, I guess, questions related to PPE and IPAC, and maybe that's something we can review at our next session in more detail. People have legitimately some worries about their own health. And then it sounds like some of you are working collaboratively in your jurisdiction, so that's good. And then some people are saying not enough hours in the day. So Brian, maybe we can we'll stop sharing the poll and we'll go to the next slides. And we're just going to close out the session. I did wanted to just let you know we've been working on a few other things that we're going to share with you through the next few sessions. One of the things that we're doing is trying to support people to be able to embed quality improvement into their practice. That's what we do at the Department of Family Medicine. And we've designed a course, a set of e-modules that people can take at their own pace. They can take whatever modules they want and we think that this would be very helpful for folks specifically if they're going through the CPSO QI program. So if you're in that boat and you want to help us out, we're looking for a couple of reviewers and happy to pay you for your time to review these modules and let us know what you think of them and how they could be improved. And if you're able to do that, it'll help us to get some main pro credits for all of us as colleagues that we could benefit from. Next slide. I also do want to share with you an initiative that I've launched together with a very big team and a big group of collaborators to really hear from the public directly about how we can do better when it comes to primary care. We know that we need a better system. There's so many issues that need to be addressed, and I firmly believe we need patients' voice to influence that. And so if you can share with your patients and your colleagues, your friends, your family, to go to ourcare.ca and take our national research survey, which is the first step in this national conversation that we're going to be having. So please do go to ourcare.ca. Next slide. And then, of course, I want to end the session by saying a huge thank you for our 50th session to all of the people behind the scenes who make this possible. Starting with Mina Viscardi-Johnson, who's been there right from the start and supports lots of things in the back end, too many things to name. Adrienne Spencer, who joined us midway through, but has been incredible support again in the back end around logistics. June Yi from the OCFP comms team, Kim Moran, the executive director of the OCFP, Brian De Silva and Olivia Neal from the DFCM, who are the folks behind the scenes who control the slides and ensure that the sessions run smoothly from an IT perspective and a Zoom perspective. Marissa Schwartz, and prior to that, Kirsten Elleridge really helped with the slides and again, some of the logistics behind the scene, getting things up on the website. Erin Plenert, our Q&I program manager, and prior to that, Trish O'Brien, who really supported the session from the back, but Trish was there right from the start with me conceiving of this as an idea, and who knew we would get to this point. David Kaplan, who's been at most sessions for the last 2.5 years, despite his very busy schedule, and is always a whiz at being able to answer questions in the Q&A and chat. And then a very special thank you to Liz McGaugh, who I feel has been a partner to me in being able to design these sessions to meet the needs of all of you, identify speakers, and ensure that we continue to keep this current. And then actually, all of our team has been amazing at being able to follow up to there's lots of work that gets informed by what we do, what we hear here in the COP. So when we hear, that people are confused about things, we take it back to key organizations and really try and advocate for better. So also just naming a lot of past folks, some of whom I named, Leanne Clark, the previous OCFP's CEO, and Suzanne Taylor, Jennifer Young, Leslie Greenberg, all of those folks are people who've joined us in the past and were parts of our team. So, and then finally, go to the next slide, Brian. I'll just say thank you to all of you for your continued participation. I think your continued participation is what's made these sessions amazing. Of course, in so many ways, it's not great that we're still here 2.5 years later. I think we all hoped the pandemic wouldn't have lasted this long. But on the other hand, I think we found a place of community where we can come together and support each other and learn together and try and sort through so much of this confusion together. And so I appreciate your continued attendance and participation and patience with us. And lastly, thank you to our panelists like Alison McGeer, Dan Warshevsky, and many others who have continued to make time for us. That's how we are able to learn, to hear directly from experts like yourselves. So our next session is planned for October 28th, 3 weeks from now. We do put out an evaluation. We really would appreciate you taking the time to fill that out and letting us know, what you want to hear in the next session specifically. We do take those comments very seriously in our planning. So thank you very much, everyone, and have a happy Thanksgiving long weekend.